Good morning, I'm Chrissy, and today we are going to talk about accessing, caring for, and de-accessing ports. The first question we would like to ask our patient is why they have the port. Do they have the port because they are currently receiving chemo? If so, then we need permission from the patient's oncologist to actually use this port. The second question is going to be, when is the last time this port was actually accessed? If it has been longer than a year, then we should not be accessing this port. Because this port is already in the patient's chest, we need a chest x-ray to verify that the port is still in the correct place. We should also be asking our patient what size engaged needle they use, and also if their port is a power port or not. If the patient cannot answer this question, on chest x-ray, you will see a radiopaque CT in the port that will tell you that the port is actually a power port. The reason this is important is because we have two different needles. One needle is non-power. It is called the Gripper Plus, and it has clear tubing. We also have the power port, which is blue tubing and is called the Power PAC. Therefore, it is important to know the difference so we can put the appropriate port needle into the patient. If it is power, it can be injected with CT or MRI to appropriately give contrast. We will need to gather our supplies. The first thing we need is a port access kit. This Vigon kit is our new port access kit. It contains flushes as well as it has everything we need except for the needleless connector, which we can get from our med room. If you still have the old kit, you can absolutely use this, but it does not contain the flushes, so we have to grab 3 flushes to access our port with this kit. As you can see, I have set up my port kit as my sterile field. I'm going to take my port needle and aseptically put it into my port kit. I am also going to do the same with my needleless connector and drop it into my port kit. The first piece in the port kit is a mask. You should absolutely be wearing a mask for this procedure. If your patient is able to, they can turn their head away from the site. Otherwise, they would also wear a mask. Next thing in the port kit is our sterile drape. We are going to take our sterile drape and drape it below the site of the port. I like to tuck it with the gown so that it keeps the gown below the site of the port. Before I sterilize and clean everything, I like to feel the site for any redness, tenderness, or signs of infection. As you can see, I have donned my sterile gloves and now I am ready to start the process. First thing in the kit is alcohol swabs. I am going to take the alcohol swabs and I am going to clean the site with each alcohol swab, just getting that first layer of dirt and or body secretions off of that site. I will use both of them and then I will move on to my ChloraPrep. There are 3 swabs inside of this. We are still scrubbing the site for 2 minutes. Therefore, since I have 3 swabs, I will scrub the site for 40 seconds. I will discard the first one. I will scrub the site again for 40 seconds. Get the whole site, the whole area that your dressing is going to cover. Scrub, 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 up and down, back and forth, however you would like. Next, I will also take the third and do the same thing. 40 seconds, I will scrub for. Next thing I am going to do is apply the Cavalon to the outside edge of where the dressing is going to stick so that it adheres a little bit better, but it also protects the patient's skin after the CHG has dried. If for some reason your patient is allergic to chlorhexidine, we would use povidone iodine and we would scrub the whole site for 2 minutes. As my site is drying, I'm going to take my port needle and remove the cap that's on the end and discard it. I will take my needleless connector, same thing, remove and discard my cap and put them together. I will take my first sterile flush out of my port kit and I will prime my needle till saline comes out of the end. And make sure that my clamp is off. And then I am going to take my dressing. First piece of the dressing is the CHG patch. If for some reason, again, your patient is allergic to CHG, we would omit this step and record that information in the port access. I remove number 1 and number 2 stays on, but number 2 goes up against the patient. I will take my port needle, put it through the split in the CHG dressing, wrap the tabs around the side, as you can see, and grab onto the gripper, which is the piece that is meant to be held while I access my port. I will remove the sheath off the end of the needle, and I like to put my hands on either end of the port needle so that I can access, aim directly for the center and push it in gently. Do not push it in so hard that it bends the end of the needle. Now I'm going to grab the tips of my CHG patch while I pull up or down on the number 2 as I remove number 2 from the back of that CHG patch. As you can see, it will stick to the patient's skin. I will remove this gripper piece by squeezing it like a clothespin and removing it and discarding it. First, I would like to pull back on my port to assure that I have blood return. I will not flush my port until I do have blood return. If I do not, I can reposition my patient by lifting the arm, laying the patient back, or pushing the patient forward. Once I get blood return, I will flush my port. At this point, I can also draw my labs. I can put the blue Vacutainer adapter on the end. I will make sure that I pull back and waste 5 to 10 milliliters of blood, and then I can remove my labs. I cannot draw blood cultures from a port no matter what, as it will show up positive if the port is infected. I will also draw my PTT last, as sometimes my patient may have some heparin in their port. When I am finished drawing labs from my port, I will make sure to flush in a push-pause motion with my sterile flush. Push, pause, a whole 10 milliliters of flush, and then grab a second flush and do the same. I want to also lock this clamp when I am finished with that. I will apply my dressing. Before I do that, though, I have a single tab down the bottom, so I will have my dressing go like this, okay? If the patient has a problem with tegaderm and has an allergy, we also have Sorbiview dressings, and that's what we would use for that. Now I'm going to apply my dressing. You will see that it will be a little tented up as the port needle does stick out just a little bit. I want to gently make sure that my port dressing goes all around and sticks to the patient's skin. I am going to remove the paper that is around the edge of my port needle, my port dressing rather, and make sure that it sticks very well. You will also see that the port dressing itself has a second piece of tape on the edge. I am going to peel it off and place it underneath of my port dressing where my tubing comes down so that I'm sure that I have a good seal underneath it there. I will also take this piece, date, time, and initial, my insertion, and I will place that on the side so everybody knows the date and time and who accessed this port. This port is good for 7 days. It should be always hooked to a running IV. If they are not ordered routine IV fluids, we are going to get an order for a KVO, which is 10 to 30 milliliters per hour of IV fluids to make sure that the port stays patent. If there is no reason for the port to be accessed and the patient is not receiving IV medications, then we should be deaccessing the port. You will see that this is good for 7 days. It is not included in the Monday morning dressing change as central lines are, and we will give this patient a CHG bath every day, regardless of whether the port is accessed or not. To deaccess the port when we are finished using it, or at day 7, if we have to deaccess and reaccess because we don't just change the dressing, we would change everything. At the end of 7 days, I will come to the patient. I will make sure that this is flushed, push, pause with 2 whole flushes before I deaccess. It may be the preference of the physician that the patient receive heparin in their port to keep their port patent. If that is the case, the physician will order heparin, and heparin flush is located in your Pyxis. It is heparin 100 units per milliliter, not 1,000 units per milliliter or 5,000 units per milliliter like your sub-Q heparin is. So it is a different item. We always use at least a 10 milliliter syringe to give any medications into any central line, and we should always do so when we are doing that. To deaccess the port, the first thing I would like to do after it's flushed is to remove my dressing gently around the edges. I pull up my dressing and I try not to deaccess my port as I do that, making sure to wear clean gloves so that I do not infect the patient. After I remove my dressing, I'm going to grab the base of my port needle and I'm going to pull up like I'm opening a can that will remove the port needle from the patient. As you can see, I grab the base and hold it against the chest while I pull up on the needle itself till it clicks, which will lock it in so I do not get stuck by this needle. I will then take this and discard it into the sharps container. I will remove my CHG patch. There may be a drop or two of blood on the patient's chest when that happens. I will use sterile gauze to clean it off and then I can tape that site. We also have Mastisol available. Mastisol is good if your patient has a hard time with your port dressing sticking or your central line dressing. You can put this around the edge. It is now included with our kits and it will help that dressing to stick. Just be very gentle when removing the dressing so that we do not pull on the patient's skin and give them a wound. Now that we have deaccessed our port, we can send our patient home and they will be all set. Any questions, please reach out to us. It is very important that when you document this, that the port is already in the LDA. If it is not, we should add it asking the patient when it was inserted. Thank you. Have a great day.